Hi, everyone. So it is my absolute pleasure to introduce you to Dr. Kelli Ryckman. Kelli is currently the Associate Dean of Research at the Indiana University School of Public Health in Bloomington. But before that, she was at the University of Iowa, where she was first a postdoc with the Department of Genetics and then moved through the ranks to full professor in the Department of EPI at the University of Iowa. Her research program focuses on the epidemiologic, genetic, and metabolic pathways that contribute to maternal and neonatal morbidity mortality, most specifically as it relates to preterm birth, preeclampsia, and gestational diabetes. I'm especially happy to have her here today, as Kelli was one of my PhD thesis supervisors, just a couple of years ago, and I have spent many semesters as her grad RA. So with that, I'm very happy to welcome Kelli here today.
Great. Well, thank you, Cassie. I'm so excited to be here and to share with you some of the work that you got to see developing when you were first in my lab, which was more than a few years ago, but I won't say how many more years than that it was. So if everyone can see my screen, today I'm going to talk about identifying biomarkers predictive of gestational age and neonatal morbidity. When we think about traditional epidemiology, we're usually looking at an exposure and how it relates to the disease. And what I'm going to discuss today is some of the molecular epidemiology approaches that we use in my lab, which really sort of brings out that black box, and we look at the biological effects that are the markers of susceptibility to the given disease that we're interested in. And there's lots of ways we can employ molecular epidemiology through looking at genomics, epigenetics, and I know some of you in the audience, Cassie included, employ these methods in your labs. You can do transcriptomics, proteomics, but I'm going to focus on metabolomics and looking at the metabolic component. And this is really the component that is closest to the phenotype itself and changes as the disease changes. So we can really look at ways that the disease is progressing by looking at these metabolites. So there's lots of examples of molecular epidemiology in disease systems, cardiovascular disease, like increased levels of cholesterol as a biomarker, cancer, so genetics as biomarkers of cancer. I think the BRCA1 and 2 are the best examples with breast cancer. Infectious diseases like bacterial infection, outbreak investigations that use antigens and enzymes or other gene products. And then I'm going to be focusing on the application of molecular epidemiology to neonatology, specifically talking about newborn screening, which is the use of metabolic biomarkers to identify serious but rare health conditions at birth. So when we look at the global distribution of deaths in children under age 5, we see that nearly half of the deaths in children occur within the first month of life. So you can see that these are labeled as neonatal deaths. And when we look at the neonatal deaths, about a quarter of them are due to complications of preterm birth. So what is preterm birth? Preterm birth is being born less than 37 weeks gestation, and about 11 to 12% of infants in the US are born preterm. And preterm babies are at an increased risk for respiratory distress, sepsis, and a host of other complications. Even late preterm infants, so those born 34 to 36 weeks gestation, are at greater risk of complications than their term counterparts, so those that are born at 40 weeks. Meaning they're 3 times more likely to have respiratory distress, 25 times more likely to have hyperbilirubinemia, 2 times more likely to be rehospitalized, and then have greater chances of cerebral palsy and death. And preterm birth is not just a condition that I study, it's also a condition that is very relevant to my personal life, in that these 2 pictures are of my preterm babies, Zach and Wyatt, that were born at 34 weeks. They were 3 pounds 9 ounces for Wyatt and 4 pounds even for Zach. He's the one in the top corner up here getting under the bilirubin lights. And they were twins born 12 years ago. And I can say that they are very healthy, happy 12-year-old boys now. So when we're thinking about gestational age and preterm birth, we really need accurate estimates of gestational age These are critical for not only the care of the child, but also for estimating prevalence of preterm birth worldwide. And you can see that when we think about gestational age, it really ranges a spectrum. So we have babies that are born less than 28 weeks that we consider extremely preterm. We have those that are very preterm, born 28 to less than 32 weeks. And then our moderate to late preterm babies born 32 to less than 37 weeks. But even within here, a 28-weeker is very different than a 31-weeker. A 32-weeker is very different than a 36-weeker. And so we think of this as a very phenotypic spectrum for what we'll see and what's related to outcomes. And we also know that the survival, that gestational age is a strong predictor of survival. And when we look at the chances of survival, for example, in a high income country, babies that are born at 24 weeks, most have a 50% chance of survival with neonatal intensive care. This is actually, this survival percentage is increasing as we're getting better and better with neonatal intensive care. But when we look at low and middle income countries, that same 50% chance of survival doesn't happen until 10 weeks later at 34 weeks. So there's still a great discrepancy in care of these babies, and the chances of survival are, unfortunately, even in the United States, are somewhat related to where that baby is born, what hospital that baby gets care in, and if they have the levels of care that are needed. Oh, is there a question? So when we're thinking about gestational age assessment, the way that we estimate gestational age is with early ultrasound. And this is first trimester ultrasound, which is the most accurate. And if we get a first trimester ultrasound measurement, we can be accurate within 5 to 7 days, which there's still quite a window in there when you're thinking about, estimating this gestational age. Last menstrual period has an accuracy of about 14 days, so 2 weeks, and it is widely used in the absence of ultrasound. There are also common methods of gestational age assessment at birth, particularly in places that don't have access to early ultrasound or where a person has entered prenatal care late or has not had prenatal care. And those include birth weight and neonatal assessments referred to as Dubowitz scores. Those methods have an accuracy of about 2 weeks, and the biggest issue with them when you use birth weight to estimate gestational age is it's not robust to infants who are born small for their gestational age. So there are many term infants that are born little, 5 pounds, 4 pounds, but they're term, and those babies are different both phenotypically and biologically than a baby that is 32, 33, or 34 weeks. So when we think about the standard methods of gestational age assessment, ultrasound is not always available in the areas with presumably the highest preterm birth rates. And most importantly, it's often not available in the first trimester. So women are not entering prenatal care in the first trimester to get those first trimester ultrasounds. So you can see that in the dark purple, these are areas that have a preterm birth rate at 15% or more. In this kind of middle purple, it's 10 to less than 15%. And so predominantly the highest percentages of preterm birth occur in Africa, in India, but also the United States. And so we, when we're looking at these global estimates, because they're being done differently. So in Africa, they're primarily using neonatal assessments or last menstrual period. In the United States, we're getting closer and closer to that first trimester ultrasound. We can't tell if we're really comparing apples to apples here, if we're comparing apples to oranges, because the way that we're measuring gestational age is not the same. So better gestational age assessment methods are important, again, for improving those critical care decisions. I mentioned that 34-weeker is not the same as a 4-pound, 38, 39, or 40-weeker. And it's important to get accurate estimates of preterm birth rates across the globe. This will allow for more targeted interventions and for us to determine the true impact of interventions that are implemented. Because if we don't have a way to accurately measure the phenotype, it's rather difficult when you deploy an intervention to then measure the impact of that. So I want to talk a little bit about metabolic markers and newborn screening and why we sort of landed on that as a tool for looking at gestational age. When we were thinking about wanting to identify biomarkers that could predict gestational age at birth, we wanted to look at things that were easily accessible and measurable, and also those biomarkers that were associated with preterm birth and gestational age. And newborn screening is a test that's performed in the first few days of life using blood taken from a heel stick absorbed onto special collection paper. Newborn screening is widely used in the United States to screen for 29 core conditions and 25 secondary targets. And almost every baby in the United States is screened at birth. And I say almost because there are cases where individuals can opt out of newborn screening. There are cases where we may miss newborn screening if it's a home birth, but in general, this is one of the sort of largest running public health initiatives that does capture about 99% of the births in the US every year where these babies are being screened. And so for these core conditions, it's recommended that you measure amino acids, fatty acids, and organic acids. Here are the different disorders. So there's 6 amino acid disorders, 5 fatty acid disorders, 9 organic acid disorders, and then a host of other disorders that are captured on the newborn screen. And the majority of these are captured by tandem mass spectrometry. So this is measuring specific metabolites that indicate the presence of one of these disorders. So this is the newborn metabolic profile for anyone that has taken biochemistry. You may be having flashbacks to this, but this is the TCA and Krebs cycle or fatty acid oxidation. So I'm not going to go through the biochemistry of this, but I just want to show that the majority of the metabolites that are measured on the newborn screen are involved in the Krebs cycle. And so these are non-essential amino acids like alanine, arginine, ornithine, and others. These are acylcarnitines, including free carnitine, and then a host of short, medium, and long chain acylcarnitines. Also essential amino acids like leucine, methionine, and phenylalanine. And then there are other biomarkers that are measured by enzyme methods, including thyroid stimulating hormone, 17-hydroxyprogesterase, and then GALT and biotin-base. So in total, when you run a newborn screen on a baby, you capture about 50 to 55 individual metabolite levels. So early on, when I first started my postdoc in pediatrics and genetics at the University of Iowa, I had an idea that I put in as a K99R00 grant that was funded, where I had been working with both the neonatologists and the newborn screening program at Iowa, and both folks were saying the same things to me. They were saying preterm babies flag positive for these newborn screening disorders, but we know they don't have the disorder. They just flag positive, and then we just have to keep retesting them and retesting them and retesting them. And we just kind of know that. And so I said, well, why is that? What is actually higher or lower in these babies, and do we understand why? And are there patterns that we can look at to see if we can start to make predictions about, why preterm and low birth babies are flagging positive for these disorders, and can we actually quantify the different disorders that they're flagging positive for? And so I got access to the newborn screening data in Iowa from 2004 to 2009. And so we had 221,787 newborns in this study. And this was one of the great things about using newborn screening is since it is measured on nearly every baby at birth, you can be able to put together a very large cohort to study these kinds of effects. And so in this study that was published in 2013 in Clinical Biochemistry, I looked at and saw that preterm and low birth weight babies had higher 17-OHP, lower thyroid stimulating hormone, in general, higher amino acid levels, and lower medium and long chain acylcarnitine levels. And we also saw they were flagging higher on the false positive rates on the newborn screen as the neonatologists and the folks that work at the state hygienic lab who run the newborn screen had already said anecdotally. But we looked at this, and so this is congenital adrenal hyperplasia. This is one of the disorders that are screened for on the newborn screen, and the biomarker for that is 17-OHP. And we wanted to break down by gestational age grouping what the false positive rate really was. So when we looked at the term population, the false positive rate was 0.2%. And when the newborn screening program looks at their false positive rates, they're just looking at all of the babies. And because, again, remember, the majority of the babies are born term, their false positive rate was looking at about 0.2, 0.3%. But when we dig in and look at those moderate to late preterm babies, 32 to 36 weeks, we saw a 4.3% false positive rate. And in the really early babies, the ones that are 24 to 32 weeks, we saw almost double that at 8.9%. When we looked at all of the disorders that are screened for using the tandem mass spec, so these are all the amino acid, organic acid, and fatty acid disorders. These are extremely rare disorders, so we pooled across to those disorders to look at the false positive rate. And we saw a 0.3% false positive rate in the term population, a 1.7% in that mid to late preterm population, and then a large 15.2% in that really little population. So overall, we were seeing an extremely high false positive rate in the babies born 32 weeks and less, and seeing, you know, an overall rate of 1.5% in the total population of the term babies. So the next thing that we wanted to do after we looked at that was we wanted to really start determining if we could develop models that were predictive of gestational age using those metabolite biomarkers that are part of the newborn screen profile. So again, we used that same population of babies. We had 230,000 babies that were screened within the first week of life by the Iowa Neonatal Screening Program, born between 2004 and 2009. And we randomly, because we had such a large data set, we randomly partitioned the data into a model building data set, which is about 153,000, and a model testing data set of 76,000. And we looked at 44 biomarkers that were measured on that newborn screen for prediction of gestational age. So this included 2 enzymes, 2 hormones, the 9 amino acids, 30 acylcarnitines, and free carnitine. In our cohort, the preterm birth prevalence was 8.9% in both the model building and model testing data sets, which is good because we want those to be the same. We used linear regression to develop the predictive model of gestational age in weeks. And our final model included 37 metabolites, so thyroid stimulating hormone, 17-OHP, GALT, 7 amino acids, and 27 of the acylcarnitines. So when we looked at model performance in our model testing data set, which was that third that we kept back after we developed the predictive model, the newborn metabolic model estimated gestational age within 1 week for almost 80% of our cohort and within 2 weeks for 95% of our cohort. And this model explained about 52.8% of the variation in gestational age. So we were able to explain some of that variation in gestational age by these metabolites that are part of the newborn screen. Neonatal weight alone explained more of the variation in gestational age than all of the metabolites together, so 54.6%, which isn't surprising because, again, weight is very highly correlated with gestational age. But I'll explain here in a minute when I show the results what the metabolites add to this that we can't get with weight. And looking at both weight and the metabolites in a single model improved the prediction to 66.2% of the variation in gestational age. So here's the performance of this in the model testing data set. And what we're looking at here is the percentage of babies that are in our cohort at this gestational age. The percent that the metabolic model predicts if we just apply that model, and then the percent that the weight only model predicts. So if we're looking at the less than 32 weekers, 1.5% of our cohort was less than 32 weeks, born less than 32 weeks. If we just apply the metabolic model, it predicts about 0.88% of the cohort. So it's under predicting the true value. And weight is also under predicting, but it's a little bit closer to the true value. When we look at the 35 to 36 weekers, we had 5.7% of our cohort in this range. And the metabolic model predicts about 3% of the cohort. The weight only model predicts about 2.7. So again, both sort of under predicting the true prevalence, but are getting closer to the true prevalence that we see in the population. When we look at the model discrimination, so between just calling term versus preterm, our area under the curve was pretty good. So for the metabolic only model, we had about 0.9 area under the curve. Weight only, we had 0.88, and metabolites plus weight, we had 0.938. So a pretty good area under the curve, and you can see that here with this dotted line. This is the combined model. But where we really see that the metabolic model performs better than the weight only model is in small for gestational age infants. So here we just took our subset of infants that were small for gestational age, and we had a cohort of 7,500 of these babies. When we look at less than 32 weekers, 1.6% of our cohort fell into that group. When we applied the metabolic model, it predicted 1% of the cohort was in that group. And you can see for the weight only model, it over predicted the number of babies in that group at 3.5%. Looking at the late preterm babies, 35 to 36 weeks, 5.8% of our cohort fell into that group. The metabolic model got pretty close at 4.3%. But again, massive over prediction here of about 2.5 times greater for the weight only model at 12.7%. So this is really where the metabolites start to refine the prediction of gestational age, is in these cases where we have small for gestational age babies. So the newborn metabolic profile, as detected by routine newborn screening, can accurately predict gestational age to the same degree and slightly better than weight alone, particularly in the small for gestational age babies. We also showed that newborn screening measurements can be used for population surveillance of preterm birth, particularly in the absence of prenatal ultrasound. And models including both metabolites and weight provide the best prediction of gestational age. So at the time that I published this paper in 2016, predicting gestational age using neonatal metabolic markers, there were two other studies that were doing the exact same research that I was. They were trying to use newborn screening metabolites to predict gestational age. And so we actually, these three groups, we found out about each other before we got to the publication point, and we decided to come together and publish these three in obstetrics back to back to back. And so this is a nice illustration of how you can be really collaborative instead of competitive. We knew we were all going after the same idea. We wanted to, do that, but be able to sort of publish at the same time. So we agreed to wait for each other and to kind of get our publications ready at the same time. And then we approached obstetrics to see if they would be interested in a suite of publications. And the very interesting thing about doing this as well is that we didn't try to synthesize methods. We didn't try to all use the same methods. So the group in California didn't use linear regression. They used a different type of regression. The group in Canada, this third one, they also used a slightly different methodology than I had used, but we all came to about the same conclusion. So our AUCs were very similar. Our prediction amount, the way that we're predicting and being able to accurately predict the prevalence of gestational age was very similar. So we were able to really get to a similar answer by taking 3 distinct approaches and using 3 different cohorts. So I used the Iowa cohort. This group used newborn screening in California. So they had many more samples in their study than I did. They had millions. The birth rate in California is much higher than the birth rate in Iowa. And then this group used newborn screening from Canada. So after that set of publications came out in 2016, the group in California and I decided to partner together to work towards applying these models that we had built to seeing if we could predict gestational age in East Africa. And so together we got funding from the Bill and Melinda Gates Foundation, and we enrolled 666 infants between September 2016 and September 2017 in the Busia district of southeastern Uganda. We had first trimester ultrasounds for gestational age, and we saw that 5.9% were born preterm. By first trimester ultrasound, 17% of the cohort was small for gestational age. And what's interesting about this study is that the preterm birth rate in Uganda was actually estimated to be much, much higher than 5.9%. It was closer to 15, 16%. And so we really do believe that a lot of these preterm birth prevalences that are reported across the globe are reflecting that small for gestational age rate rather than the true preterm birth rate. So for this study, we had a heel stick specimen that was taken within 3 hours after birth. We sent the samples from Uganda to the state hygienic lab in Iowa for measurement of the same newborn screening metabolites that we had used to build the model in Iowa. And then we took the beta coefficients from the Iowa model using the 37 metabolites to predict gestational age in the Busia cohort. We also built Busia specific models after we did the initial prediction. And so again, this is a collaboration with the UCSF Preterm Birth Institute and funded by the Bill and Melinda Gates Foundation. So this publication came out in 2021, where we were able to look at gestational dating using the newborn metabolic screening and validating in Busia, Uganda. So when we look at this is looking at the difference between the heel stick model determined gestational ages and the ultrasound determined gestational ages. And this is really the Iowa model. I really asked them not to name it after me. I did not want an algorithm named after me, but here we are. It's in this paper, so this is what happened. But I'd rather it's an Iowa model. But this is the model that I present using the Iowa data. And so we, when we applied that model to the Busia cohort, we got 22%. That was a perfect match. 42.5% that was either a perfect match or within 1 week. Or no, I guess this is the cumulative. This is 42% that was within 1 week and 35% that was within 2 weeks. So when we look at the cumulative frequency, we're able to predict within 2 weeks over 80% of the cohort. When we recalibrated the model just to using the Busia data, it's not a big surprise that the results got better. That's what we would expect. But we got within 90% for estimating within 2 weeks of the gestational age. So for this model, 81.2% were successfully dated within 2 weeks of ultrasound. And when we refined the model to the local population, we got, as I said, about 90% of the cohort within 2 weeks. You can see the sensitivities and specificities here for the 2 different models. But really what we're showing here is that metabolic dating is a reliable method to determine gestational age in a low income setting. And it could be important for assessing population level patterns, for tailoring clinical care, and for understanding the developmental trajectories of preterm babies. So the next section that I want to talk about is how we've now moved from applying these metabolic markers to prediction of gestational age into really looking at the metabolism and these specific metabolic markers and how they're related to the morbidities of preterm birth. So babies that are born preterm, particularly those that are born less than 32 weeks, are at an increased risk for intraventricular hemorrhage, which is brain bleeds, patent ductus arteriosus, which is a condition affecting the heart, respiratory distress syndrome, and bronchopulmonary dysplasia, which affect the lungs, retinopathy of prematurity, which affects the eye, and then necrotizing enterocolitis, which affects the gastrointestinal tract. And so identifying predictors of neonatal morbidity and mortality is important for risk stratification, family counseling, for external benchmarking across hospitals, and also for precision medicine. So in 2013, I had used that same, or I had been working with these newborn screening profiles, not only to look at gestational age, but I also had taken a data set from the Iowa Biobank that we had, where we had 689 subjects, and I was able to link that to the newborn screening data. And this was a preterm cohort born between 22 and 36 weeks. We again had around 44 markers of amino acid and fatty acids. So these are the acylcarnitines and amino acids. And these were measured 24 to 72 hours after birth as part of routine newborn screening. And so I looked at these different morbidities, so respiratory distress syndrome, patent ductus arteriosus, NEC, retinopathy of prematurity, and congenital anomalies. And we saw that phenylalanine was associated with respiratory distress syndrome, and then these essential amino acids, leucine, methionine, and phenylalanine and valine were associated with patent ductus arteriosus. We wanted to then extend that by replicating those same findings into the large California cohort. And so here we looked at over 100,000 preterm infants, where we had newborn screening data linked to birth certificate data. 9.2% of the cohort experienced either mortality or one of the major complications of prematurity. And there were 6 characteristics and 19 metabolites that were included in that final model. So what you can see is that this is sort of a heat map showing, what was protective versus risk, depending on how you look at it. But all of these metabolites are associated with our composite outcome of morbidity or major, or mortality or major morbidity. And then when we divide across the different single complications of prematurity, we can see different patterns here. So we've had a lot of publications that have looked at these metabolites and neonatal and infant outcomes. We've looked at persistent pulmonary hypertension, hyperbilirubinemia. We even have a publication on association of these metabolites with the risk of wheezing in childhood, and also with necrotizing enterocolitis. So we do see different patterns of these metabolites as being important in these conditions of neonatal and infant outcomes, particularly in babies that are born preterm. And so we took that existing body of work, and the group in California and I put in an R01 and got this multi-site R01 funded that's called PROMPT, Predicting Maturity, Mortality, and Morbidity in Preterm Newborns. This is a multi-site R01 from UCSF and University of Iowa hospitals and clinics. The study timeframe is 2020 to 2025, so we're about halfway through the grant. And our hypothesis is that metabolic biomarkers can be used to accurately predict the risk of neonatal morbidity and in-hospital mortality in preterm babies born less than 32 weeks gestation. And again, we're hoping that understanding these predictors will be important for risk stratification, external benchmarking across hospitals, and informing precision medicine. So in AIM-1, our goal is to develop and externally validate metabolic models for predicting neonatal morbidity in very preterm newborns. We're using a retrospective analysis of the metabolic profile data captured by newborn screening. And here we have an electronic medical record data set of just over 1,300 very preterm neonates from the University of Iowa Hospital linked to their newborn screening data. In AIM-2, we're going to evaluate dynamic metabolic models for predicting neonatal morbidity at multiple time points within the first week of life. So this is a prospective enrollment of 400 preterm, less than 32-week gestational age newborns and their mothers. And we're just under half. COVID kind of screwed us up a little bit because we started this grant right during the height of the COVID pandemic. And so recruiting less than 32-week babies is already a big challenge, but right in the middle of COVID, you can imagine it's an even bigger challenge. So we're a little bit under our recruitment goals, but we're close to about halfway through recruitment with 178 subjects across the 2 sites. And we've been banking, we collect 5 samples during the first week of life, and then we're also banking samples every other week until discharge. And so we have 605 samples so far in this cohort. So a great bank of samples for both this study and studies that we plan to do in the future. And so we wanted to first examine this data in the California cohort, because again, they had that large linked database of retrospective newborn screening data linked to the birth certificate data. And they had already done some preliminary data prior to us starting the grant, where they had shown that metabolic profiles are associated with 7-day survival among infants born 22 to 25 weeks gestation. And here you can see that the metabolic patterns were strongly associated with survival. So that's the red here with an AUC of 0.885. And it outperformed the standard clinical characteristics that are often used for predicting mortality. And that had an area under the curve of 0.685. So we wanted to rebuild this model because that model that they used in California was for peri-viable babies, so 22 to 25 weeks. And we wanted to be able to apply it to the entire cohort less than 32 weeks. So we rebuilt the model for mortality using the California data and tuned it to neonates less than 32 weeks gestation. And in this California cohort, the mortality rate was 8.4%. And then we applied the model to an internal validation cohort. So we had held back a third of the California cohort to apply that model to. The final model included 6 characteristics and 9 metabolites. So you can see those listed here. I won't read them out. But again, very high AUCs using both the combined characteristic and metabolite model. So what we wanted to do next was externally validate this in the Iowa cohort. So for our Iowa cohort, we had that electronic medical record database of 1347 less than 32 weekers. After excluding those with missing outcome data or those who died before the first day of life and did not have matching newborn screening records, we had 1,240 neonates born less than 32 weeks with metabolites. We had a 5.2% mortality rate in this cohort with 1,176 babies that survived to discharge. So we took the full California model and applied it to the Iowa data using a prediction score. And this prediction score was calculated by summing those beta coefficients from the California model based on the value of the respective variables from the individual babies in Iowa. And what we got was an AUC that was pretty good of 0.819. You can see the 95% confidence intervals here. I think this should be 0.762. There's an extra 0 here. But a pretty good model that's predictive of that. So we're showing external validation of this original California model. So the implications of this are that we did show that distinct metabolic profiles can aid in the prediction of complications of preterm birth, including bronchopulmonary dysplasia, interventricular hemorrhage, retinopathy of prematurity, and necrotizing enterocolitis. Metabolic patterns may lead to molecular pathways for specific complications of preterm birth, because we looked at composite outcomes here in many of the work I presented, but we've also shown different patterns when we look at individual complications. And we're hoping that this work may be used to inform precision-focused treatments for these different complications. So I want to acknowledge the host of people, and I can't even fit on the slide all the people that have been part of this work. Cassie certainly is, saw the beginning of this work back when she worked for me as a GRA, so I think her too. But those at the University of Iowa lab, the funding that we've had from Bill and Melinda Gates and the Preterm Birth Initiative and NICHD, the folks at the State Hygienic Laboratory, and then all of my UCSF collaborators have been instrumental in this work. I'd also just like to do a plug that we're hiring for faculty and postdocs at Indiana University. So, I figured students are in the audience. So when you're starting to look for positions, please consider us. We have 5 departments all looking for great faculty and postdocs. And there's the URL if you're interested. And now I'll take questions.
Thank you so much, Kelly. We're all clapping.
Yeah.
So Yusuf, you're the one that runs the seminar, I think, right? So I'll let you want to just, I don't know how you normally do questions anymore.
Yeah, I'm just, people raise their hands basically when they have. Sue has a question.
Yeah, that was a wonderful talk. It's something that I don't know much about, so it was, it was nice that I actually understood it really well. So thank you. So I have a question for you. It was kind of related to the first part of the talk, the metabolomic prediction of preterm birth, and you looked at the metabolic model, weight only model, and the combined. And my question is for the combined model, did you kind of re-estimate everything? What I was thinking of is particularly going to like low resource settings. I would think you would kind of want to start with a model that begins with weight, because they'll always have that, and see what you can do with metabolites to add to it, to optimize it, but to keep the minimum number of metabolites. And I was just wondering if that's
yes.
what it was, or.
Yep. So that's a great question. And we did a little bit of that in Africa, where we refined down the number of metabolites that we were using from that 37 to a smaller set when we got to the Busia cohort. I think there's more work that we can do there in refining that model, because we are looking for sort of that best set, that has the smaller number of metabolites. We've sort of have had debates though in the community about it, because once you get that heel stick blood, you can, the newborn screening panel is sort of set. So it doesn't cost less to do 4 amino acids than it does just to do that whole panel. In Iowa, the whole panel is $50 a sample. So it's not inconsequential amount of money, but it's not also what we think of in genomics, like thousands of dollars a sample either. And so, there's been kind of debates back and forth about, do we need to find 1 or 2 that can be done there, or if they have to be done on tandem mass spectrometry because it's an amino acid acyl-carnitine, then why not just do the full panel? So I think, a lot of that is still going on in the community between how best this would be implemented.
Great. Thank you.
So these panels are routine, for example, in Uganda and other African countries for newborns?
No, not yet. So we ran those samples here. I will say that thyroid stimulating hormone is pretty routine across different countries. Most countries are now establishing testing for TSH. Tandem mass spectrometry is starting to come aboard to some countries in Africa and Asia, low income countries I'm talking about, but isn't quite, is still a ways away from being fully implemented. You can imagine that there's a lot of difficulty capturing newborn screening in these different countries than the US. So in the US, the model of birth is delivering at a hospital, right? So not everybody, there are people that have home births, but the majority of people are delivering at a hospital. That's sort of the norm in the US. But in other countries, that's not the norm, right? So home birth is the norm. So then you get into this whole, how you get the specimen, how you get it to a lab, how you get it tested becomes very difficult. So we don't think of this as necessarily in every, we're going to look at every single baby that is born and be able to predict their gestational age for clinical care. When we were thinking about this towards low and middle income countries, we were thinking more about taking a sampling of individuals to be able to get more accurate estimates of the preterm birth rate. Because like I said, right now, their surveillance rates are probably really off because they're really using only weight. And that's really showing us the prevalence of small for gestational age, not the prevalence for preterm birth.
That's great. That's exactly where my question was going is that, in many countries now, especially I know in Eastern Africa and other parts of Africa, there is a deployment of lots of community health workers that do basically this job of, counting the newborns, like when you are in rural areas, and also even following the height, weight trajectories. And I was thinking about these dry blood spots, for example, whether it's possible to measure these same metabolites with a good accuracy and in dry blood spots, because they're easier to take even if you're outside the hospital. And
yeah, so we did, it's very interesting. So part of the results I didn't show is that I also did a validation study in India, Bangladesh. And we did a lot of work in Bangladesh with how to get the samples to the hygienic lab to do the testing, because as you point out, so it is easy to take a dry blood spot measurement. Easy as in, I'm going to do air quotes easy, getting a spot. It's not full phlebotomy. It's taking the heel and getting a drop of blood on this dry blood paper. But there are actually transportation issues that we found when transporting the samples to the US, in that humidity was a big factor for affecting the metabolites. So we did different conditions and showed that if you didn't put them in the desiccant bag at the right time, the humidity in these countries actually affected the metabolite profile. And we got really kind of whack results across the board on these metabolites that tanked the prediction. We discovered, time on dry ice shipment versus just shipping without ice was a big factor. And so a lot of this, we do have a publication kind of showing the transportation issues that you have to consider. So it is an easier way than, full phlebotomy, but there were still some interesting transportation and humidity issues that came up that affect the metabolites. So they aren't completely stable once they're on that dried filter paper.
any questions from other people? So I'll follow up on this actually, because actually I was talking more not about the DBS on cards, more about the VAMS, like the volumetric absorptive microsampling, that which actually protects, like, it dries inside quickly, and also you don't have the hematocrit effect that actually exactly what's the denominator.
Yeah. So I think that is, something that we didn't consider for this particular study, but is really interesting to sort of think about for future studies.
Yeah, and I know some people have developed some great pipeline for metabolomics, whole untargeted metabolomics, just in those small
Yeah.
advanced devices.
Yeah, I've looked a little bit into those advanced devices, but I'm kind of stuck with the state hygienic laboratory because I guess I'm like, stuck in the old ways. But I do agree with you that I think the newer technologies are things that we need to start exploring.
Yeah, and there are so many coming out, like in the last 3 years. I think with COVID, there is some EpiPen, some.
Yep, I looked at the HemiSpot, which is another one that's
Yeah.
really good. Yeah, there's lots. I just haven't been brave enough to try anything new yet.
Yeah, I'm trying some of those, so I let you know.
Oh yeah, let me know how they
Yeah.
how will
Yeah. Good. Any other questions, guys? No? Okay, so thank you so much, Dr. Ryckman. That was amazing.
Thank you so
I
much for
really,
having me.
yeah, I enjoyed it. And thank you very much, Cassie. It's like